Hello, everybody, and thanks for joining me. I'm going to start our screen and we'll get into this breakout session. So my name is Kathryn Luchok, and I am a medical anthropologist in the Department of Anthropology, also cross-trained in public health, and also in the Women and Gender Studies program at the University of South Carolina. These are my co-authors who all contributed to this work. And what we're going to share today is how much do sticky messages stick, and look at both short-term and long-term evaluation of a reproductive health literacy workshop. Traditional sex education has some problems. Not everybody does this, but a lot of traditional sex education really ignores the issues of reproductive literacy and how people can really chart their own reproductive destinies. There is not much normalization and not much connection that's focused on most traditional sex ed. It's often fear-based, preachy, and downright boring. And it's also steeped in clinical details, the curse of knowledge, where what we know inside our heads, we think everybody knows, and then we don't give people the information that they need to know in an understandable way. They hear yada, yada, yada. So this doesn't positively inform people. It often diminishes the connection between people. It discourages mindfulness and undermines personal empowerment about sexuality. So there's 6 attributes of sticky messaging, and these were created by Chip and Dan Heath, who are psychologists, who wrote the book Made to Stick, Why Some Ideas Survive and Others Die. So they said things like urban legends never die, right? Why? Because they're simple, because they're unexpected. Brain research shows that something surprising sticks in our brain longer. They're concrete, easily understood, things that are everyday, and they're also things you can touch and feel and see. They are credible, they make sense, and they're from credible sources. Emotional, they get us to be emotional. We think it's funny, we laugh, we cry, whatever, but the emotion helps it stick in our brains, and we are wired for stories, narrative stories, storytelling around the fireplace. All these things help to make a message sticky. It is success. That's their sticky way of talking about sticky ideas. Linda Robinson, who's pictured here, is the nurse practitioner who came up with the workshops, did the workshops, and came up with the sticky messaging. She had never read their book. She was doing sticky messaging before they even wrote the book. However, this helped her put it in a way that we could talk to other people about it. So here's some sticky messaging, the male reproductive cycle. She talks about this cream. She puts it in a teaspoon. This is the typical ejaculate. How many sperm are in there? She'll ask an audience. They'll say 100, 100,000, 1,000. She'd say that would be sterility. She opens up the liter bottle of sand and starts pouring it out. Sand after sand after sand, 350 to 500 million sperm, and they love their job. Women have their reproductive cycle inside. So a lot of times they don't have a relationship with something they cannot see. So she wanted to make it visible to people and fun and funny. What are your ovaries but glorified egg cartons? We have a nest just like birds do, and we fluff it up just like birds do. And when we have an egg, it helps to nourish it when it's fertilized, and when it's not, it's deleted and it goes through the tube. This is a toilet paper tube. So this is all stuff you might have around the house. It's inexpensive, it's fun, it's colorful, it's funny, and people notice it. She puts it on a belt when she does this and walks around and talks, and it's very, very funny. If a female wants 2 children, she spends 5 years trying to get pregnant, actually being pregnant or postpartum, and 35 years trying not to. So people misunderstand their menstrual cycle, and they think that it cleans them out. She says Lysol would come out if that's what it was. And, it's really just about the reproductive cycle. South Carolina ranks 11th out of 51 in teen pregnancies. Even as the rates are going down, we're still a high teen pregnancy rate place, but foster care, and why we went to foster care is girls in foster care are 2.5 times more likely to get pregnant. Nearly half are pregnant by age 19, have at least one child by 19. They're a high-risk population already at a deficit because we have terrible sex education in our state, and it's not medically accurate. And if you miss that day, and kids in foster care are more likely to be moving around and miss the one day it's sex ed day, and then they don't get any sex ed at all, even deficient sex ed. This is another way to look at it. The dark blue are girls in foster care, the light blue, girls not in foster care, and you can see at each age level of pregnancy, much higher rates for girls in foster care. So we decided to provide innovative workshops using sticky messages that focused on normalization connection. And we talked to both the staff and the teens. The sticky messaging uses humor, everyday language, simple analogies and metaphors, and concrete things you can touch and feel to make reproductive facts easily understood. We use normalization. We try to focus away from shame and fear and taboos. And connection is promoted by not having you this and you that, but rather we message it, right? We are all people, and we all have bodies, and all these things happen to everyone. And it lets us be seen and valued without being judged. 60 group home staff participants and 108 teen participants, workshops at 5 group homes and 2 Urban League foster care homes. We were in the South Carolina Midlands. 1.5 hour workshop, only one of them for staff, teaching them to be reproductive health warriors, why they should support reproductive literacy with their teens, how their personal stories both keep them from being able to have connection, but also if they remember what it was like being a kid, they can connect better. We also gave them sticky messaging they can use, and lists of it so they could use it. The teens had 2 1.5 hour workshops, and we did normalization, connection, puberty as a human universal, and then anatomy and physiology in that kind of simple and fun way, and sticky messaging. And we used a toolbox. It really is a toolbox that she takes with her. And here's the contents of the toolbox. The M&M years from menarche to menopause. That machine is going all the way through that. We also did double C's, IDDF, I don't do fluids, contraception and condoms have to be there. What's in fluid? If you don't want to get pregnant, nothing that you need. There's where the disease is in the fluid, and then sperm, of course, can cause a pregnancy. So wait till you want to get pregnant, then you can exchange fluids. We didn't have very much money. We did an internal evaluation, although I did hire a doctoral student who's since graduated to do the actual analysis. We collected baseline pre-test and immediate post-test information. We used PrEP CDC questions. We collected narrative data from open-ended questions. We did process data. We entered and analyzed the quantitative and SPSS, and we did ANOVAs and the basic, some basic analyses. We also had narrative data reviewed for themes, and we did a 2-year follow-up that was all qualitative with staff only. We would have liked to have done teens, but did not have the ability to do so. So that's a future study. Teens range in age from 10 to 21, but most of them were 13 to 15th in the 8th to 12th grade. The majority African-American, and then other ethnicities and races represented. The majority female, majority reported they were straight, but we did have gay, lesbian, bisexual, and other identities. 47.7% reported that they had ever had sexual intercourse. And of those currently sexually active, 40% had used contraception. Not very many had gotten anyone pregnant or been pregnant, which was good news. And 40% of them were not active in the last 3 months sexually. Here's the baseline in the last 3 months for those who were sexually active. And you can see that nearly half of them had none of the time used contraceptive or none of the time used condoms in those 3 months. So bad news there. Post-test, the intention to use, not behavior, but at least on the way to behavior. To use contraception and condom in the next 6 months, what's your plan? Almost 60% said contraception, much more likely. Almost 60% said condoms, much more likely. And if you add it in, somewhat more likely, you're going to go closer to 70%. Only 2.8%, much less likely to use either of those. Lots of information afterwards that they said they knew more about contraceptive methods. Half of them felt more comfortable talking about to the staff about these issues. 86% knew more about accessing birth control, more confident choosing a method. We had them actually see methods and touch them and insert Nuva rings into models and things like that. They understood more about the female system and the male system, and 37% said they were more likely to abstain from sex in the next 6 months. So sex ed, hey, it didn't make them want to go out and have sex, which we know it doesn't. Over 85% strongly agreed or disagreed that they knew where to get birth control. That was significant at 0.001. That they understood all the choices of birth control, significant at 0.001 at post-test as compared to pre, and would feel more comfortable talking to a doctor or nurse about birth control. We did ANOVAs to look at some differences, and gender came out as a difference, with boys gaining more than girls in the post-test. We think maybe because boys are at a real deficit, they get their information from the internet and from each other, and maybe never get it from any trusted source, and so they had more to gain. That's a guess, but we think it might be plausible. The staff also had a wide age range. 65% were African-American, 85% female. Most of them reported being more comfortable talking with teens post-test about these issues. 91% better prepared to be an advocate for helping them access contraception. 84% post-test knew where to refer for contraception as compared to 71% pre-test. Some narrative data that was more realistic, open and not sugar-coated, said a teen boy, truth and honesty, easier to talk to clients, but also to my own children. A lot of people went out and had sex talk with their kids for the first time because they finally felt comfortable doing so with our information. 2-year follow-up, it was all interviews. It was mostly phone interviews because COVID had started, so she had to stop in-person interviews at the time. Messages really stuck with the staff. They could recount in detail the details and the catchphrases. They said they were still better able to have discussions with teens under their care about these issues. They were more confident in referring teens to services. The teens were more knowledgeable about their bodies and how to advocate for themselves, and were better able to talk to their own children still about health and puberty and things like that. Here's just some quotes that you can read on your own because they're a little bit lengthy, but I did want to point out that they credited us with being trauma-informed and body positive, that a lot of people had religious and conservative backgrounds, and this helped them get over the shame and being able to talk to people without condemning them. Lots of details that this visual learner remembered from the visuals. Engaging people, we heard over and over again that kids really perked up and listened because we talked at their level and we used language that they use, and really catered to the kids. And that was different from a lot of workshops they had. I love this one. It's about, they felt they were queens. They made crowns and they wore them all the next day because of all the information, she says, that Linda had given me and my staff. The Groups that did education were more informed. They verbalized what they needed and wanted. Hey, I'm on the pill. I saw this training. I want to try something else, longer acting reversible contraception. Um, Lots of topics discussed. This person does continuing education, is using our materials in that, even at church groups. And someone else said they can talk at church functions to teens, preteens. It opened my eyes a lot. And I also called my grandparents to tell them it's okay to talk about sex. We've used it in lots of other groups. You can see here, Healthy Start, Pasos immigrants work with community health workers, centering groups, domestic violence shelters. Our funders, $25,000, the Anna Layla Burdock program. Thank you very much. Not very much money to do this, but certainly helped us get this far. In-kind support for printing and things like that from the Department of Anthropology at USC. The Women and Gender Studies program provided travel funding both for our earlier pre stuff at APHA a couple of years ago and at City Match a couple of years ago, and now our follow-up data at APHA this year, and in December at City Match. So contact me if you'd like to talk about this. You might want to think about incorporating sticky messaging into the sex ed that you do. I'd be happy to talk to you more, and we'd love to get this out to more places so that we can get enough data to become a promising program or a proven program, so that we can finally get compete for CDC funding and other kinds of funding. So thanks for talking with me. I'm going to stop my share now, and I hope that you enjoy all the breakout sessions that you go to.